We'll give it another minute here for people to log on in. All right, good afternoon and welcome. I'm Josh Miller, a project manager with Rural Health Redesign Center, and I'm here with Tom Harlow, program director. Thank you for joining us today for part one of our empowering webinar series, Safety Strategies for Managing Agitation and Aggression. Before we begin, a few housekeeping items. We encourage you to submit any questions in the designated Q&A section. We will do our best to address them during the session, and any remaining questions will be answered when we release the session recordings. Your participation is greatly appreciated. Also, we want to let you know that part two of our webinar series will be on April 24th at 1 p.m. We will send out additional information and registration for part two of this series. Today's webinar focuses on essential issues in healthcare, ensuring safety in interactions with individuals who may present challenging behaviors. Healthcare professionals frequently encounter situations that require both skill and confidence to manage agitation and aggression effectively. This session will provide practical de-escalation techniques, personal protection strategies, and mindset shifts to help create a safer and more professional work environment. At the Rural Health Redesign Center, we recognize the growing importance of workplace safety and violence prevention strategies in healthcare settings. This webinar is designed to support rural healthcare organizations in implementing best practices that reduce risk and promote a culture of safety. Today, we have the pleasure of introducing Brendan Riley, an expert in healthcare security and violence prevention. With over 24 years of experience, Brendan has led security, emergency preparedness, and workplace violence prevention programs across multiple healthcare institutions. He is a certified healthcare protection administrator, a recognized industry leader, and an advocate for improving workplace safety in healthcare settings. Through his expertise in de-escalation, crisis intervention, and proactive safety strategies, Brendan aims to equip you with the skills needed to confidently manage difficult situations while ensuring professionalism and security. Without further ado, I'll turn it over to Brendan.
Thank you so much, Josh and Tom, and for the Rural Health Redesign Center for having me as today's presenter. I'm really honored to be in front of this audience, and I've been very involved for many years with International Association for Healthcare Security and Safety. And several years ago, they tapped me to be their presenter at American Hospital Association's Rural Healthcare Leadership Conference down in San Antonio, Texas. I had to tell them, hey, full transparency, I'm city folk. I've never worked in the rural environment or a critical access hospital. But we proceeded, and I had enough of time leading up to the presentation to get to network and learn an awful lot from folks working across our entire country in the rural health space. And I have such admiration for the great work that you do. As you well know, you're the have-nots of healthcare. And even further than that, you deliver healthcare its purest form to small communities, treating your neighbors, the folks you see on the Little League field and in the grocery store. So I have so much admiration for the work you do and the confines in which you do it. Sometimes we feel very under-resourced here in the big academic medical center, but we can afford to make mistakes and pivot off them and recover just fine. And I know from the folks I've worked across the country in the rural setting that if you're not making every decision right, you could be shuttering your doors. And this is such a critically important topic. It's a massive, complex topic, workplace violence prevention and healthcare. But to me, this is the foundation. I wanted to start here This is what our caregivers and our healthcare workers are navigating on a regular basis in their practice. Agitation and aggression that is directed towards them. So this is a kind of a two-part webinar here. We're going to start out by really talking about building our mindset and understanding. I want to try to supply the why things are as intense as they are right now towards our caregivers. And we're also going to wrap up with covering some great skills that we can deploy in these really intense moments when we're engaged with people who are emotionally confrontational towards us, up all the way up to including being violent towards our care teams. So this is where it's at for me. And when we develop our mindset, I think we just need to tap into our core values as caregivers, the things that make us great at what we do in the care environment, I think can also make us safe on the job as we try to navigate conflict. So I've been at this for going on 25 years. I'd like to say I've been involved in well over 10,000 encounters with folks who are emotionally confrontational, every population of person imaginable, many, many times over. And I made an awful lot of mistakes along the way, particularly in my early career as a uniformed security professional. But I've often learned a lot over those years. And these are my biggest lessons that I like to share with audiences. And the first one is that lashing out at healthcare workers seems to be a coping mechanism for people who are in pain, stressed out, frustrated, humiliated, or afraid. And isn't that almost everybody in our care? Deep breaths help before going to start any encounter. Walking away helps. Letting someone else take over helps. Giving second and third chances is effective. Accepting apologies and starting over is just the right thing to do. It's hard to do, but often the right thing to do. Not judging these patients and their family members is hard work, but I step out of bounds as a professional when I choose to react emotionally instead of responding thoughtfully. Taking it personally happens to even the best of us. Forgive yourself and commit to doing better next time. We try to live up to our professional core values, but if we ever step out of bounds, when a patient or their family members in our face screaming, swearing, spitting right in our face in anger, it's okay as human beings if we're not our best self in that moment. But we want to reflect and learn and commit to doing better next time because there will be a next time. These people would do better if they could do better. And I heard somebody in psychiatry say that years ago, and it always just kind of stuck here with me. I've seen so many people at their absolute worst working in the hospital here, and I'm sure that you can all relate. We encounter people that are living a train wreck life. We might be engaged with them after they've just lost a spouse or a child, the worst moments imaginable. And oftentimes those factors impact people's behavior. And just realizing that sometimes just helps me not take their bad behavior so personally and remain professional. And lastly, kindness works wonders. And so does sedation, medication, and antipsychotic meds. Real talk here. If you've ever encountered these out of control violent at the bedside, sometimes nothing will stabilize that behavior more effectively than the medications designed to do just that. However, don't miss the major point there. People feel our core values. People feel our empathy and our kindness, even when they're behaving badly. They also feel when that kindness is absent during those moments that they're confrontational towards us. So we always want to be mindful of that. Healthcare expectations in 2025 and beyond, we all know these with the people in our care. When do they expect their care to be delivered? Right now, right? What do they expect the quality of that care to be? Perfect every time. It doesn't matter that she's a 78-year-old lifelong smoker after three complex heart surgeries. She should be recovering as good as any 30-year-old. And if she doesn't, it's your fault. And what do people expect to pay for this perfect health care? That's right, free health care for all, right? It doesn't matter how much debt our professionals are going into for their education to qualify. for these roles and the millions of dollars that we spend on state-of-the-art medical equipment and technology and facilities, there is that growing thought that this should be a free entitlement. And I'm sure this is a virtual room full of great caregivers today. None of you can deliver perfect, free, and now. And the reality is, the root of all conflict, folks, is pretty simple. It's just two things: bad past experiences. Heck, we've all had those, right? As patients ourselves or our family members who are being cared for as patients. And most of all, the root of all conflict is unmet expectations. We cannot deliver perfect, free, and now. So we have to understand that folks are going to be in what I call the emotional brain state of mind. So many of our encounters with folks in healthcare facilities, the emotional brain is in the driver's seat. The thinking brain shuts off like a light switch, and the emotional brain takes full control. The emotional brain is not capable of logic and reasoning. It's very capable of being emotional and fight, flight, or freeze. I'm a non-clinical person, but I've tried to learn an awful lot about the brain, and this really makes sense to me when we think about the folks that we encounter. The thinking brain is shut off, emotional brain in the driver's seat, and we see people oftentimes escalate quickly to explosive and potentially violent behavior. And I'd like everybody to try to relate to this on a personal level. The way I do it is at the grocery store. That's really what activates me to be overly emotional. I do all my family's grocery shopping, and I like to go early Sunday morning, 7 a.m., got my run to the place, in and out of there like that with the full grocery list. But I've tried to go on Saturday afternoon at like 4:30 p.m. and it's wall to wall people everywhere. Can't even get a parking space at the grocery store, slamming carriages into each other in the aisles, and then going to the checkout and it's 10 carriages deep, and there's aisles that are closed, and I'd tear my hair out if I had any in those moments, and it really activates me. I'm gonna be the one whose heart's racing. I want to go over to the people working at the grocery store and say, "Hey, you, go over there and open that aisle. Do it now." But obviously, I'm able to do what so many of our patients and their family members cannot do in our care. I'm able to regulate my own emotions in that moment and never scream and holler at the grocery store workers, to just settle myself and deal with might be a bad experience. Because at the end of the day, we're talking about groceries. We're not talking about my son's health care in that moment. So often people in our care cannot do what we become accustomed to doing, and that's self-regulating our own emotions and turning the thinking brain back on. So hopefully, I think sometimes understanding this concept can help us in these intense moments. And I'm fascinated by agitation and aggression. And the analogy I always like to point out that most of us can have some familiarity with is these super aggressive drivers, swerving back and forth across four lanes of traffic, no regard for their own personal safety, right? Never mind anybody else that's driving on the road. They're trying to get from point A to point B faster than the rest of us. They probably never accomplish that objective, but what's going to happen the next time they're out there driving on the highway? The same behavior. It is just a hardwired personality trait. And I came across a theory many years ago that 20% of the population's primary means of communication is aggression. And that came out in the mid 1980s in a study called Violence in the Medical Setting. Here in 2025 and beyond, I'd say jack that up in regards to that personality type characteristic. And hopefully we can relate to this too. Think about your extended families for a minute. Do we all have that real alpha personality in the family? They're always right. They'll argue with you about anything, and goodness forbid you slight them. They must have retribution. Sure, those personalities are sometimes more commonplace than we realize. And when you bring them into a healthcare setting, it can be a perfect storm for violence. And this is the U.S. Bureau of Labor Statistics information here, and this is why you're all on the webinar today. We're familiar with these facts of the prevalence of violence, which was epidemic before COVID-19 in healthcare and global, but is really accelerated as we continue to recover from the global pandemic. Our bedside caregivers are far more likely to be subjected to non-fatal assault from violence than any police officer or correctional officer. Law enforcement leads out when it comes to fatal injuries from violence, but we lead out by a wide margin when it comes to the non-fatal stuff. Bedside caregivers are at the greatest risk. Why? Simply stated, opportunity. To do their job requires to be up close and personal right at the bedside, providing episodes of care with every population of person imaginable, including those experiencing active risk behaviors. So the opportunity is ever present for our bedside caregivers. There's much that can be done to prevent and mitigate violence, but we can't eliminate that opportunity through the very nature of the work. But we can be strategic, just like we are on the highway. If you're driving with your family and you're coming across one of those super aggressive drivers, if traffic jams up, does any of you throw it in park and get out and run over to the other car and start pounding on the windshield and tell them to knock it off? Of course not. In those moments, you look inward. You focus on protecting yourself and your family with your defensive driving, and that's all that matters to you. Yet, from my perspective, all over our country, caregivers might approach the equivalent of that aggressive driver who's laying back supine in a hospital bed and say, "Hey, buddy, we can do this the easy way or the hard way." And then get punched right in their face in the process. So I think we need to really focus inward, just like we do on a highway with the dangerous driver, when it comes to potentially dangerous patients in our care, and be really strategic how we navigate those moments. Really compelling image here. And we have to stand united. When I travel across the country, I hear far too often, well, violence is just part of the job. It's what we signed up for. No, it's not. And we have to stand united against that type of mindset. None of you signed up for combat when you walk into work in a non-military healthcare facility. All right. We could be in combat situations, and everybody would universally agree that the prevalence and the severity of violence has never been higher in healthcare than right now, but it's not okay. We've got to stand united on that fact. We need to be the solution, and we'll certainly talk more about how we do that. But violence to me includes the completed physical assault, a lot of the physical stuff, but also that rampant verbal abuse, those threats of violence and harm is in that bucket. We have to stand united against that. But I always like to ask caregivers, is disrespect part of the job? And I stand in front of many, many nurses and ask this question over the years, and there's no right or wrong answer per se. But probably my favorite response is someone will shout, "It shouldn't be." And that's the answer I wholeheartedly agree with. That as caregivers, every one of you deserves to be treated with the utmost respect at all times by everyone in your care. But the question at the top of your screen is not should disrespect be part of the job? The question is disrespect part of the job? And when I ask caregivers for shows of hands of who has shown up as your best professional self, reflected your core values, and still been treated disrespectfully by a patient or their family member in your care, every hand goes up. And it's usually something that has occurred over and over and over again. So I think our reality is we're going to see people at their worst who are suffering, who are struggling, who have those unmet expectations, whose emotional brain has total control. And I think disrespect is often symptomatic of people living through moments like that. There's got to be a line between disrespect and violence. And I think we all across our organizations need to work to clearly define that. And if anybody has any past work experience in any of these really customer service related fields, we're all human services workers, healthcare, and all of these folks as well. Maybe we're not apples to apples, but we share an awful lot of common when it comes to interacting with people. And if you have this type of past work experience, I'm sure you remember exactly what your manager told you was rule number one. And even if the customer is wrong, they always default back to that rule number one. And I grew up as a teenager working at a large grocery store, and I learned an awful lot more about effective conflict resolution working in that grocery store than I have in any hospital. And I think a lot of it had to do with this type of mentality and an anticipation that we would be treated disrespectfully by those in our service. But once that happened, then what? How could we respond thoughtfully in those moments to bring the tension down and achieve a safe outcome? I'm calling for that to really be kind of our mindset. Candidly speaking, whether we want to realize it or admit it or not, oftentimes in healthcare, we do the inverse of this. We're always right. It's our patients and their family members that are always wrong. And if we approach them when they're in conflict with that type of mentality, the results can be disastrous. And I'll share a little secret with this group. Back when I worked in the grocery store as a teenager, we were right probably 99% of the time, the people who worked there. But 100% of the time, we defaulted back to these golden rules here. And it was just very effective. These folks usually do two things really exceptionally well: service recovery. The really agitated, angry person over their experience, here's 25% off next time. The tension comes down. And they're really good about kicking it up to a person in charge. And I've been in a healthcare environment a person in charge for a long time. And I remember when I wasn't, I would be the daily lightning rod for people's aggression and disrespect. And now it's the people who work for me that are often in those shoes. But as a tactic, they can call me into that encounter. And I'll tell you what, every time, when I show up, the agitated, angry, disrespectful person, as soon as I walk in the room, they're a perfect lady or gentleman. The tension comes down because they perceive a person in charge is now entering a situation. I think that's an effective tactic. I think we can often do that in healthcare. Sad reality for those who are nurses on the call. I hear it so often, the white lab coat effect of when the doctor walks in the room and that nasty patient or family member is now prim and proper, who is just terribly disrespectful towards the nursing staff member. Excuse me. Believing that others will react as we would is the single most dangerous myth of intervention. That's one of my favorite quotes. Gavin DeBecker wrote that in the great book, The Gift of Fear. When I first came across this, I underlined it, I highlighted it. It's in the chapter about restraining orders. And it really resonated with me. I did this so often in my early career without ever even realizing it. Face it, what we can relate to best is our own experience as human beings. So unconsciously, we very often project what we would do in a certain situation or circumstance onto the person in our care. And the result can often be disastrous, particularly when we're engaged with people who are wired quite a bit differently than the way we are. Often, what we end up doing is we apply a reasonable person standard to the most unreasonable people among us. So, just something I hope everyone can reflect on as we navigate these moments. To me, we do this all the time across US healthcare. We continue to do it without realizing it. And here's Exhibit A. These zero tolerance campaigns and these signs that are lists of thou shall nots of behaviors that occur with frequency in most healthcare facilities that say that we're going to remove you, we're going to prosecute you, and that's never followed through upon. And we lose all credibility in the process, especially with our workforce, when we are powerless to follow through because of systemic issues outside of our control with the justice system. So just something to kind of reflect on conceptually here. It's really resonated to me and helped me change my practice. I used to champion zero tolerance and signs like this. I put them up for years in my hospitals, but I really analyzed data closely, and the trend lines for our volumes of violence and our severity of violence were upward for years, and it took me a while to realize these were pretty adversarial. They weren't reaching our target audience. They weren't having the effect we wanted. It took me years before I took them all down. And on the webinar part two in April, I'm going to talk about that more extensively because there is a place for a public facing message that reflects our expectations and our values. But I would argue it's absolutely not this stuff. And I think we have to advance past it as healthcare. So I'll ask this group here, what is really causing all this bad behavior? Seldom, if ever, it's the caregivers. It's directed at them and it's terrible, but seldom, if ever, is it about the caregivers. And I always like to gather audiences of caregivers and have them come up with a list of contributing factors or precipitating factors that's really causing the bad behavior. And hopefully you've answered this question to yourself here. And I'll show up with a group of newly licensed nurses recently came up within a course here. Pretty heavy list. We think about our friends and extended families, pretty relatable list. And I think nobody is their best self that is navigating the world, experiencing any one of these factors, never mind a number of these factors simultaneously when they're coming into a hospital setting where talk about the loss of personal power and the fear of the unknown takes that emotional brain by the wheel. And I've intentionally put early childhood trauma in red there. In my health system, we have a list of our top 10 most violent individuals that we care for. And that's one common denominator all 10 of those individuals share. They're survivors of early childhood trauma, physical, emotional, sexual abuse as young children. And again, I'm not saying that excuses their bad behavior, but maybe it helps explain it, if that makes sense. It certainly helps us not take the bad behavior so personally. And at the root of our values, I sincerely believe, is empathy. That's often the tie that binds us as caregivers, big medical centers, rural hospitals, any part of the country. I think that is one of the big tie that binds the folks who do this noble work. And I think part of empathy is recognizing the patient perspective. I'm going to throw up a crayoned note that an involuntary commitment psychiatric emergency department patient crayon to themselves as they were boarding an emergency department for days and days and days, trying to be placed into a bed that just doesn't exist in the state here. And I'll give you a moment to read it. I'm not sure it matters, it does to me, but come to find out the author of this crayon note, who had been a 25-year registered nurse, who had a breakdown later in life, lost her chosen profession, lost her family, just for a matter of perspective. And sometimes we take away more rights than a maximum security prison, and we have to. We have compelling safety reasons why we have to do that. However, we should reflect on how it must feel to be in that other set of shoes or slipper socks so to speak, in these moments and help inform us as we navigate those relationships. I heard there was a recent webinar offered to, through the center about the adverse childhood experience study. This really, really impacted my learning. If you're not familiar with it, I'd strongly encourage you to do a bit of research. Kaiser Permanente and the CDC did this massive study in the late 1990s. If you look in the results there, it's just the impact of adverse childhood experience and the devastating effects on adult health status, particularly when it is relating to heart disease and cancer and chronic lung disease and liver disease, et cetera, et cetera. Really, really important stuff. Because as caregivers, we see the sickest of the sick. We see a disproportionate share of people who are survivors of early childhood traumas. That's why trauma-informed care should be at the center of our training and our education efforts across the board, no matter what type of environment you work in the healthcare setting. And lastly, on the mindset side, I just wanted to share a reflection, a comparison, some perspective. This is borrowed or stolen from Dr. Ruth Poteet, who's a very, very prominent addiction medicine specialist up here in Western Massachusetts. The best speaker I've ever seen on any subject matter. And I asked her permission to share this comparison. I'll actually share Dr. Poteet's words with you. Two people come into the ER. One had acute STEMI, the other an overdose. One gets brought to the cath lab, ICU, admitted for 5 to 7 days, brought to cardiac rehab, started on 4 medicine, social work consult. The other is given a dose of Narcan and kicked out the door. Are the 30, 60, and 90-day mortality rates actually higher for the OG than acute MI? One may be 24 with 60 more years of potential life ahead, the other 84 completely different care. And boy, did that resonate with me because I've been around hospitals for 25 years. And I'll tell you what, Grandpa, he gets our best always, without judgment and without exception. Nobody cares if he's still smoking butts. Nobody cares if he's eating red meat every night or he's not taking his daily medications. We spring into action and he gets our very best without judgment and without exception. But her, I think at best inconsistently. And Dr. Poteet puts it squarely on medicine and the judgment that still seems to exist amongst a lot of caregivers when it comes to caring for those in the throes of substance use disorder, particularly opioid use disorder. And as a non-clinical person, I like to share my perspective on the sidelines, so to speak, for many years here. I see probably the best analogy in how we care for the chronic alcohol use population. For generations ago, I think medicine realized that it's impossible to care for those patients in the throes of alcohol withdrawals medically without treating the alcohol withdrawal symptoms. Years ago, that was probably the most violent patient population I used to see in our hospital was those in the throes of the alcohol withdrawal, but they seem to be eradicated because of medicine, because of the CEWA protocol, because of the standardized plans of care in treatment for those with chronic alcohol use. We're really not there nationally when it comes to caring those with substance use disorder relative to treating their withdrawal symptoms so we can take care of them medically. Very often, those folks, their withdrawals not addressed, and just the other medical factors are cared for, and usually the results can be disastrous. Street drugs coming in, undesirable folks entering the facility, overdoses and deaths of the street drugs in hospital beds, and tragedies of that like. However, I think our values should be distributed equally across the board. I've spent thousands of hours in my life in hospitals with people in the throes of substance use disorder, and not one of them, from my perspective, was popping pills, shooting up, get high, and party time. From my perspective, these folks were using for two reasons: not to be dope sick or not to cope. with whatever their circumstances were very often impacted by trauma. So I learned many years ago not to judge, and I think that just aligns best with our core values as caregivers to, despite a lot of the terrible, nasty behaviors that are, subjected to us, really try to find our best selves and our best core values and care for people in a manner that's non-judgmental, is really the foundation of our mindset, of how we can skillfully navigate these encounters. And when it comes to skills, I really think it starts here. Most caregivers would rate their job as extremely fast-paced and high-stressed, at least some of the time, and often all of the time. So, what can caregivers do to really detach and put themselves in the position to be their best self when they show up for their workday? What type of routines before work? Be well rested, get a good night's sleep, eat well, focus on your exercise and your health, have a conversation with a loved one, tighten up all loose ends before you set foot into your workplace for that day. Maybe, have an agreement like I do with my spouse that there's no such thing as an urgent text message. There's such thing as an urgent call, but there's no such thing as an urgent text message. So we don't have those lines of communication becoming disruptive as we focus on a stressful workday. During the periods of the highest stress, I'm a big proponent of really deep breaths and what those can do for us physiologically, just bringing our own tension down. So often as caregivers, we know we're going to have to go into the room with somebody in crisis. We're going to have a really difficult conversation. We're going to have to deliver really bad news. So before we go to have that encounter, take some really deep breaths, box breathing, and what that does to our tension, and lean on each other. Go to your peers and team up when we know it's a really stressful day. And then after the worst day ever, we need to channel that through trusted resources. We need to express how we feel and what we've been through. That might be the silver lining of the pandemic, as it's becoming more and more common for that to occur. But candidly, I'm still alarmed by the suicide rates for physicians and nurses. So I think all of our organizations need to be very strategic about developing these resources and making sure our workforce knows how to tap into the employee assistance program, spiritual care and chaplaincy, and other resources that might be available for them. Empathic listening is where it's at. This might be the most valuable skill in a healthcare environment. Because think about it, what's more important to our patients and their family members? What you have to say or what they have to say? And I'd say always it's what they have to say. So tee them up, open-ended questions. What's going on? How can I help? What's most important right now? How can we make this right? And then being that empathic audience for them. All these bullet points are really important. Nothing's more important, though, than the top one, being non-judgmental, putting our judgments as human beings aside and showing that kindness and that genuine caring. The best way we do this is often non-verbally. Here are our gestures, our postures, our facial expression, our eye communication in these moments, sitting down and being at eye level with folks. And I like to say, you want to show that individual that you understand without ever saying, I understand. Because I found early in my career, if I ever said, oh, I understand to somebody who's in the throes of methamphetamine addiction, you don't understand what I lived through. Of course, I actually don't. So show them how understanding you are without ever saying, I understand. I often say the opposite. I can't even imagine what you're going through right now. Language matters. Um, American Hospital Association has a great campaign. People matter, words matter. So let's be really intentional and really professional about the language we use. Too often in my career have I seen caregivers physically attacked by patients in their care after referring to them as drunks or junkies or psychs, things like that. And Sometimes if you slap a label on people in crisis, it's very relationship damaging. And sometimes how people can save face is with these by getting physically violent. I've seen it occur far too often. No caregiver deserves to be physically harmed, but we better learn and we can do better. And the example I like to share is the regularly used term of the frequent flyer for the patient that's well known to us. I'd say save that for the airlines because I once had a patient observer thrown halfway across a crowded emergency department after referring to a patient who was right there in bed as a frequent flyer. He got up, grabbed her, and threw her. She was seriously injured. She did not deserve that. But again, we ought to learn and we know we can do better. So be intentional and be professional about your language. Don't ignite that potential for violence. Disruptive behavior is something that really bothers us in healthcare. It doesn't really necessarily have much of an effect on us if we're seasoned healthcare professionals, but we know how impactful this is on our other patients and their family members. When somebody is screaming and swearing and disrupting the entire environment of care. But strategically, I'm calling for us not to engage. Don't pick up the rope. Don't get into the power struggle. Actually, the most effective tactic in a moment like this, as uncomfortable as it may be, is to allow the person to vent. So they're yelling, screaming, swearing, disrupting, let it run its course. Because think about it, if you've ever been in the red zone in your personal life, overwhelmed with emotion, do you want me walking over to you and say, hey, ma'am, you need to calm down? No, that's gasoline on the flames in a moment like that. It is for all people. So very often, I'm a proponent of what I call watchful waiting. Get over to a safe distance and you monitor this person without direct intervention. There may be times using your own discretion where you might be able to engage the person to bring them to a more private area. I'm a big fan of the walk and talk with a disruptive person. Excuse me, sir, but if you can come with me, I'm going to bring you to a private room. I'm going to call the person in charge. If we can get them over to that more private space, it might bring the tension down. And oftentimes you might be more strategic to try to affect the audience. Because usually if somebody's yelling, screaming, and swearing and disrupting, it attracts a lot of other patients and visitors and others who, heck, they'd order popcorn and soda to come over and watch this go down. So in those moments, I found we can be impactful if we try to have an effect on the audience. I've done it so often, I have a script for it. It's always, hey, folks, this is a real private matter. You're safe. Please go back into your room so we can help this person. Thank you. That type of messaging. And I found very often when we are really intentional about it, folks will then go back to where they belong and bring that stimulation down for this person who's disruptive. Most importantly on this slide, if you feel as though the situation is becoming unsafe, it already is. Trust your gut, trust your instincts, move yourself to a position of safety away from this individual and get more help with whatever your protocol is in your organization. So communication is certainly really important as well. Nothing's more important than nonverbal communication. Like I mentioned before, particularly when it comes with our listening skills, but also when we speak, it's not necessarily what we say, but how we say it. Our paraverbal communication, our tone, our volume, our cadence. We want to do our best to project calm confidence in these moments with the agitated, aggressive person. It's hard. It takes a lot of training, and I think it takes some experience to really channel that calm confidence, that ability to take a step back, take a deep breath, and just be really even. A steady hand with your nonverbals and just real even with everything that you have to say to that individual in those moments. So there's a feral cat on the screen here. I'll out myself as a cat lover. I'm a cat dad. I've got 4 Siamese kitties at home. So if I ever see a feral cat on the side of the road, I'm going over. But do any of you think I'm going to run over and say, hey, kitty, and start trying to pet her? Of course not, because she would tear my face off. But as a cat lover, I'm going over, but I'm going to go over slowly, cautiously, calmly, supportively, and I'm going to lean in. And that's always, I think, our best approach as caregivers, even with that agitated, aggressive person. Lean in, try to be supportive with our approach, even when they're upset and angry and emotional, as a de-escalation and a safety tactic. Of course, we need to have an assertive response, but I say keep that in the back pocket. All right, we want to be really strategic when we have to be assertive and start giving options to somebody and really escalating to a more directive type of approach. Always do that as a team. We want to team up with other members of our working group when we get there. Putting our egos aside is really important. And what I mean most by this is having the willingness and the ability and the system developed to substitute out. If the person you're interacting with, you have no rapport with them, heck, they are perseverating on you. They are fixating on you. You're being your best professional self, but they are just hating on you. Should you hang in there as the primary person communicating with them? I would say, of course not. And it used to happen to me so often in my career, I developed a script for it. Hey, I sense I'm making this worse. I'm going to step out. And I didn't go to the cafeteria, but I got a direct line of sight. And so often, when another colleague would enter into that situation, the tension came down. And heck, sometimes the patient would have their chest out. They told me where to go and how to get there, but we got the outcome we were looking for. The situation was now under control. Come up with plans with your colleagues, lean on your peers, come up with strategies. If we're having to go in there and deliver bad news or have a difficult conversation, what's plan A? What's plan B? And lean on each other and have that team support. Setting limits is an art form I'll talk about in a moment, and just bringing that mindset forward into this. If somebody's really remorseful, we want to be prepared to accept apologies and just start over, focus forward, forward, forward. Um, Limit setting, I could do an awful lot of time about this, but I think most importantly on the screen here, choose wisely what you insist upon. When we're caring for people in crisis, there's a lot of stuff we have to insist upon for safety, but be really wise about it. Here, don't, sometimes we can set things aside for now if things are really escalating to a boiling point. Anticipate what the common refusals are. And here's an emergency department example. Some of the stuff the care team has to insist upon that people often refuse to do. Well, what are some potential incentives? And you can see some of my keys here of how to have a real structured, strategic limit setting with an individual in crisis. And number five there, you know, positive choice, but if you choose not to, consequence, we're going to give you a minute to think about it, then you can decide. Just being really strategic in these moments, but understanding they're in the driver's seat here. Hey, we're just presenting options. They're going to be the decision maker. I found this is the most valuable skill set for those who are effective with de-escalation. Verbal de-escalation is really strategic, effective limit setting. Personal protection planning is so important as well. So much of the violence in healthcare right now is occurring right at the bedside. It's reactionary, patient-generated violence. So I think really focusing more on how we approach the bedside with good balance and good stance and good mindset, that if somebody starts grabbing and hitting, that we block and we more importantly move. We get away from the bedside to protect ourselves in those moments. We disengage. Where so often somebody's grabbing and hitting, all of our caregivers dive in. They're trying to grab something, they've got control of nothing, and it's target practice. And people are getting seriously hurt here. So I think really developing those skills and that mentality at the bedside is center and foundational to our personal protection planning. Something as simple as always having an escape route. And if you can't, if you have to be compromised with your access to getting out a door, go in there as a team. Have buddies at the bedside amongst your care team if you can't own the door, so to speak, and understand how do we activate an emergency response in our facility all the way up to and including, those run, hide, fight principles, with run being most important, getting away from the threat. There's an over reliance on panic buttons in healthcare from my perspective. I always ask the question, push the button, then what? Okay, what about that gap of time, which in rural health is often really extensive. Sometimes the help's not even coming. So how do we navigate that gap of time? Again, activating emergency response, critically important. Push the button, then what? I think we need to empower our caregivers with options of how to protect themselves and keep themselves safe until the help arrives. The technology is great, but that's not enough. We have to consider what I refer to as the extreme danger gap. All right, I think I have time just for a quick personal reflection here. Owning a response is hard in healthcare. It really is when people are terribly disrespectful and mistreating you. But I'm going to share a personal example. That's my wife there smiling on your screen, and I tell her story with her permission. My wife is Janina. She works at Boston Children's Hospital. She's been in caregiving for many years. Little background on her. Janina is a new American. She was born and raised in Dominican Republic. She came to the States as a 19-year-old seeking asylum and did not speak a word of English back then. And she went through a years-long process and bureaucracy to become a naturalized U.S. citizen. And over the course of all that process, she learned how to speak English. She learned how to read English, how to write, how to comprehend, to the point that she has a master's degree in healthcare administration from Regis College, which to me is pretty big time. Um, as an adult, I've been trying to learn how to speak Spanish my entire life, and I can't do it. I know all the swears, but I'm not even conversational, and I've tried hard at it. So big time respect to any adults who can learn a second or third language. There's so many people who work in caregiving here. And Janina, I call her Smiley. She's like the most positive, high energy person that I know, and she loves working in healthcare. And years ago, we worked at the same hospital, and I was coming home after a really brutal long day of work, and I'm like one half a step in the front door, and I see Janina sitting on the edge of the couch, and she's like, "Brendan, you better sit down so I can tell you what happened at work today." So I'm like, "Oh boy, what's this all about?" I sit down, she breaks in a story of what happened that morning on our surgical daycare unit. At the time, Janina was working as a certified medical interpreter for our Spanish-speaking patients and anesthesia and nursing in the surgical daycare. She loved it down there. They had a great team. But she told the story of how she was racking up an encounter with anesthesiologists and the patient, and she was heading over to the nursing station to pick up the next assignment when another patient's family member stepped out of the surgical bay and said, "Hey, you, come over here." So my wife, being Janina, was all smiles, walked over. "Good morning, sir. How can I help you?" He said, "Have you packed your bags?" I said, "Excuse me?" "You heard me. Have you packed your bags? You better. They're gonna deport you." So now it was definitely me on the edge of my seat, because the Janina I know outside of work is no joke. You disrespect this woman. I've seen her square people away at restaurants and hotels. So I'm thinking, oh my goodness. Like, is this the story of like a security stat call on Janina? Did my team have to run in the surgical daycare and pull her off of this dude? So I finally get around to just saying, "Oh my goodness, Janina, what did you do?" And she said, "Brennan," I just smiled, shook my head, walked over to the nursing station and picked up the next assignment. So I was just like, yes. And I was certainly like, woo. But wow, for so long I've been preaching to caregivers, Q-tip, quit taking it personally, which is so much harder to do than say. And I've been disrespected thousands of times as a longtime caregiver. But I could never relate to that. What it feels like to be discriminated against like that, I cannot relate to. But I'm really proud of my wife for upholding those values of a caregiver, even in a moment of hate like that, by disengaging and rising above it, really, I think reflected those core values. So thank you for giving me the opportunity to share that very personal example of owning one's response. So finally, here are what I hope were the contributions of our hour together here. Probably most importantly, the top one, kindergarten golden rule. I know that. But the second part there is where we come in and our values as caregivers. And at the bottom there are the five universal truths I learned very early in my career. And I think that they really, really are the foundation of how I try to interact with people who are in crisis in a healthcare situation. So with that, here's my contact information at the bottom of the screen here, and I'd welcome anybody to reach out to me that may have any direct feedback or questions for me. Um, I'll turn it over to Tom or Josh if there was any feedback during the presentation.
Great, Brendan. Thank you very much. And again, would encourage folks to make sure you look forward to attending the second of these webinars coming up in April. Brendan, just a couple things, more of a comment. I'm going to try to synthesize it a little bit. But I think what this individual was trying to get at is there's still opportunity within healthcare. And some of this is driven by system factors. It could be things such as the number of shifts, the overtime, a lot of the stresses that are put on the caregivers that also contribute to some of this. You talked about empathy and things like that, it challenges the caregivers too. And just wonder if you can talk a little bit about some of those system pressures and how that might play into this.
Sure, great point, and I agree. And what I'd have to offer is kind of twofold. I think just every organization has to be really intentional about having programming that they can offer their colleagues to help them cope with the intensity of the times we're living through in healthcare right now. And those programs are meaningless if people don't know how to tap into them. So whether it's on an intranet site or however a specific organization does it. And another thing too is understand we're all human beings. Just like I never judge our patients, I also never judge our caregivers. And we've had plenty step out of bounds as professionals. We always create a pathway for them to come back from that. Oftentimes we have to mandate training and we have to talk about what happened when they were not their best self. But we do so without judgment because we do know how folks can crack under the enormous pressure and intensity of the times that we're working through.
Yeah. Brendan, again, just a comment, not a question, but an individual that posted they think fear is a huge factor, and I'm presuming that's fear on the behalf of the patient, the unknown. We know it being in healthcare, but they're coming into a strange situation. How does that influence some of their behaviors at times?
Oh, sure. I think that the people will lose so much personal power and they're so fearful that they often will latch on to what they can control. The biggest factor as I travel across the country that's leading to preventable physical assaults from my perspective is the insistence on taking behavioral health patients' cell phones. And very often this is our lifeline. It's like part of the human body for all of us, including our behavioral health patients. And time again, I've seen an otherwise cooperative patient refuse to give up their phone. Now we have a physical fight on our hands. Now we have a preventable restraint occurring with injury to patient or staff. So that kind of just popped to the front of my mind is just different and how people navigate that fear of being. Have you ever lost your phone or misplaced it? So we all know how that feels. Imagine if you're going to be without it for the next 4 days.
Yeah. And Brendan, this may, I know we're up against time, but this may tie into session two. Question came in, are there additional de-escalation techniques or trainings that you could share to help staff feel more comfortable using the calm confidence skill?
Sure, and I'd welcome anybody. I threw my contact information out there, but it's also available through the Rural Health Redesign Center. I'd be happy to make a connection with anybody that has that specific question. I might not necessarily endorse one system or the other, but there are plenty of options out there, and I can definitely share more information.
Yeah, great. Well, I know we're at 2 o'clock, Brendan. On behalf of all of the attendees, thank you so much. A very timely topic. And again, I would encourage folks that attended today, sign up for the second of the series on April 24th. Josh, I think I have that right. So again, more information will be coming out. And as Brendan said, I think he opened the door. If you have any questions, certainly reach out, and look forward to having others attend the upcoming session in April. So, Josh, anything I forgot at this point before we wrap it?
Perfect.
All right. Well, great. Brendan, thanks again. Thanks to all of our attendees, and wishing everybody a great afternoon, and look forward to seeing many of you again in April 24th. Thank you. Have a great day.
Thank you.